Right, welcome. My name is Marcin Wlodarski, and I am a pediatric hematologist at St. Jude Children's Hospital in Memphis. As the co-chair of this session, alongside Daria Babushok, I will introduce first the first part of this session, which focuses on germline genetic testing in aplastic anemia. So as we all know, this disease requires prompt treatment, but the role of germline genetics remains unclear. And although some patients have an underlying germline predisposition, the big issue here is that comprehensive genetics or genetic testing can actually be very time-consuming and delay definitive therapy. So this session aims to explore the current knowledge that can help us optimize genetic testing in aplastic anemia. Lisa McReynolds will discuss the evidence for genetic testing in all patients undergoing transplant, and Fabian BEIER will talk about the need for germline genetic testing for telomere diseases. Then we will have two talks that represent a more selective approach. Jong will talk on the low value of germline genetic testing in newly diagnosed pediatric aplastic anemia patients. And Fernanda Gutiérrez-Rodrigues will explore clinical predictive factors that may help differentiate acquired aplastic anemia from inherited bone marrow failure syndromes. The first part of the session has 4 presentations, 10 minutes each, followed by a Q&A session and panel discussion at the end. Then in the second part of the session, we will have David Sykes and Terje Solhaug, who will talk on discoveries of syndromes associated with aplastic anemia, namely CTLA4 and STAT1. Now I hand over to my co-chair.
Yes, hello everyone. It's a real pleasure for all of you to be here. I'm Daria Babushok from University of Pennsylvania, and we will start off now with a talk by Dr. Lisa McReynolds from the National Cancer Institute.
Good morning, everyone, and thank you to the session organizers for inviting me to talk today. As I think everyone in this room knows, acquired aplastic anemia, the inherited bone marrow failure syndromes, and hypoplastic MDS can be difficult to differentiate. And a number of studies in the past have estimated the prevalence of germline disease in patients with aplastic anemia and MDS. Several studies starting in 2015 looked at small cohorts of patients and showed a germline finding in between 18 and 11%, and then in a slightly larger study between 5 and 19%. And today I'd like to review 2 larger studies that looked at the rate of germline findings. I think the other important factor is, we know that recent WHO and ICC criteria have, for MDS, really focused on the fact that we need to understand these germline predispositions. And as we'll hear later in this session, more new genes are being discovered each year. And just to remind everybody what the genes and biological pathways that we're talking about here that underlie A and MDS, these include hematopoietic transcription factor biology, cell signaling, telomere biology, DNA repair, and ribosome biology. So first I'd like to review an article by Feuerstein et al. They looked at 400 patients with MDS undergoing related donor stem cell transplant. All of these patients underwent germline screening. They were unselected for age, physical phenotype, or family history, and they identified 7% of patients with a germline likely pathogenic variant. And they, in this paper, discussed that this is probably a significant underestimation due to the strict criteria that they used for calling these as germline. And these variants occurred in a variety of biological pathways, including immunodeficiencies, telomere biology, DDX41, which is the most predominant in adult MDS, bone marrow failure, and DNA strand break repair disorders. Interestingly, they found a correlation between age at presentation and biological pathway. So you can see in the plot on the left that by age decile, you can predict what germline finding you may have. And you can see initially in the younger age groups it was predominantly SAMD9 and SAMD9L syndromes, followed by GATA2, then the double-strand break repair, and then followed by telomere disorders, and then more cancer predispositions, and finally DDX41. And on the right, you can see an interesting plot that shows you the odds ratio of identifying a germline variant in a certain biological pathway based on age going less than 40 or over 40, with the balls being relative to the p-value. I think the most interesting thing from this paper, and what I think is most important, is that regardless of age, the germline rate of a germline finding was greater than 5% here. So 5% is this green line that I added to the figure, and you can see that the germline percentage is in the solid line, and the dotted line actually gives you the estimated factor that if they had included some additional findings would be there. And this is important because the rate of greater than 5% correlates with the NCCN guidelines for germline testing. Additionally, the ACMG 59 actionable list says that if there's a pretest probability between 3 and 5% or greater, that we should consider testing. So it's really important that we see this across all MDS patients, a germline rate greater than 5% regardless of age. If we turn to aplastic anemia, our groups surveyed 732 individuals who underwent transplant for aplastic anemia at a CIBMTR center. This was all comers and encompassed a wide time frame, and this was what we say a real-world cohort, because these were all patients who had been seen and evaluated and then ultimately ended up getting transplant. None of these patients had clinical suspicion for an inherited cause of their disease, and very similar to the MDS cohort, we identified a 6.6% rate of germline cause for aplastic anemia. Additionally, we found that 10% of these individuals were carriers for an autosomal recessive bone marrow failure disorder. These, again, come from various biological pathways, the most common being the telomere and the hematopoiesis disorders, and then some DNA damage, as well as ribosome biology disorders. The carrier frequency is shifted a little bit to the more autosomal recessive inheritance pattern genes, such as the Fanconi anemia genes and other DNA damage response genes. And interestingly, this really matters in terms of germline transplant outcome. So if you can see here, the individuals with no variant are shown in blue. Those who had an unrecognized inherited bone marrow failure are in green, and the carriers are in red. And the individuals with an unrecognized inherited bone marrow failure had a twofold increased risk of all-cause mortality with a significant p-value. So identifying these patients really does matter for their transplant outcomes. So, we have shown that family history and physical features often do not reveal the presence of an inherited syndrome, even amongst expert clinicians who see these patients. And data from 2 large unselected cohorts indicate that these patients are unrecognized. And this is true even in the most recent time frame where we have better and better tools. Genetic testing speed and cost is really improving, and it's becoming easier and easier to get germline tissue. And genetic testing is really mainstream in 2024 and not siloed in the genetics departments where I think people have often thought. And more clinicians are being trained on how to interpret these results. And in collaboration with our genetic counselors, we can really provide the needed guidance to our patients. So identification of a germline cause for aplastic anemia or MDS can change the planned preparative regimen and the GVHD prophylaxis for transplant. Tailored regimens do improve transplant outcome. Identification of a familial variant can influence donor selection and lead to the identification of affected family members. An identification of a germline disorder can change medical screening and management for the patients, including other cancers and other organ systems that may be affected. And I think most importantly, across the age groups, the rate of identification of germline predisposition in both aplastic anemia and MDS is above the 5% threshold recommended for treating, and hence the conclusion that all aplastic anemia and MDS patients should receive genetic testing. Thank you.
Thank you, Dr. McReynolds, for the excellent presentation. Now we will move to, please keep your questions for the end of the session. We will move to the second speaker, Fabian BEIER from Aachen University in Germany, who will talk on testing for telomere biology disorders in AMDS.
So, ladies and gentlemen, dear colleagues, it's an honor and pleasure to present you here some data why I think it's very important to test all patients with aplastic anemia for telomere biology disorders. Since my previous speaker, Lisa McReynolds, already showed you the importance, why it's important to correctly identify TBDs, I would just, conflict of interest. Why it's important to test for TBD patients and plastic anemia. When we talk about testing for telomere biology disorders, we talk about telomere length screening in this specific case. We want to first start what are the recommendations by the guidelines. And there are very few guidelines about plastic anemia, and I want to show here the guidelines from the British Society of Hematology. And here in the chapter for diagnostics, it's point 15. It's an emerging diagnostic test that can be used in cases for classical dyskeratosis congenita, but not so specific for adult aplastic anemia patients. There's another nice review from Amy DeZern, an approach to how to diagnose aplastic anemia. And here it's proposed that telomere length testing should be carried out in patients under the age of 40, and if they're older than 40 years old, in case if they undergo allogeneic stem cell transplantation. What is the basis for these recommendations? I think you all might know the data from Do It All, published in 2009, when they really analyzed various groups of bone marrow failure syndromes. And here in the groups of patients with aplastic anemia, quite small cohort, 33 patients, they really were able to identify patients with a telomere biology disorder by telomere length testing. Another work from the group of Marrow in a hospital-based setting. Here she nicely showed also in some few patients, but showed that the telomere length testing can identify patients with a genetically confirmed TBD, and separates nicely from patients with autoimmune acquired aplastic anemia, in particular in patients below the age of 40. I also want to show you some third guideline. That's the German guidelines. Unfortunately, they're really in German, not in English. But you see here in red, you see that's a mandatory telomere length testing. And this is, implementation of the telomere length screening was implemented in the guidelines in 2018. And it's really closely connected also with the aplastic anemia bone marrow failure registry we're heading in Aachen. It's a quite simple registry. So the inclusion criteria is when the treating physician suspects a TBD, the patients will be included in the registry. There are no exclusion criteria. It's important for you to know that all patients that were screened mandatorily in the guidelines from the plastic anemia were also included in the registry, restricted to the German-speaking region, and it really has a focus on adult patients. We become 85% of all samples from university hospitals, some local hematologists. So almost all university hospitals are participating. And what we see, we've done screening of approximately 1,200 samples in the last years. Half of them were newly diagnosed cases of aplastic anemia. And since we're receiving approximately 100 samples a year, that's estimated 60% of all aplastic anemia cases newly diagnosed in Germany. So I think what I'm showing you now is quite some real life what we can expect when we do telomere length testing. It's a paper we published last year. This is the first 262 patients when we do prospective real-life flowfish screening. You see the lymphocyte telomere length as the most sensitive and specific testing here. And I want you to just carefully remember this is from all, when the treating physician thinks it might be a TBD, we get 20% of all patients have telomere length below the first percentile. And if you then do the genetic testing, 10% of the whole cohort really has a genetically confirmed TBD. So we're really enriching patients by telomere length screening, like half of them patients below the first percentile, short telomeres. If you use another trigger, like the 10th percentile, we get approximately 30% of all patients for genetic testing. If we go a little bit more in the data, here on the left you see the different diagnosis category, what the treating physician thinks, if it's aplastic anemia, unexplained cytopenia, DKC, MDS, or ELD. I want to focus here on the aplastic anemia. What we see is that in the bright blue, you see the patient we screened without any variants or any genetic findings. Then we see in orange the VUS and the pathogenic and likely pathogenic variants. When you look what variants we can find in these old adult patients, typically we find TERT and RTL1, also in the VUS. And we also did analysis of all the other patients who haven't screened with the telomere length above 10 percentile. We see here some known polymorphisms, but only 2 TB-dated VUS. So I think with applying the telomere length screening, we can really enrich for VUS and also for likely pathogenic or pathogenic variants. As I told you before, we were screening quite a lot of samples in the last years. This is the data of almost 500 patients with aplastic anemia we're screening. You see here on the left, lymphocyte telomere length screening. In contrast to the work from Marrow's group, we really see like a broad distribution of telomeres also in the young. And if you look for the numbers, 30% of all screened patients have telomere length below the first percentile and 27% below the 10th percentile. We're also something about the age cutoff with 40. We really see that also in the patients older than 40, we really see patients with really short telomeres. And we're doing at the moment genetic workup with whole exome screening for everyone below the 10th percentile. Unfortunately, we haven't all the data done here. I can tell you that below the first percentile, of course, we find the TBD patients with confirmed TBDs. But what's interestingly, we also see between the first and the 10th percentile other inherited bone marrow failure diseases like GATA2, we have NF-kappa B like immunodeficiency, ERCCL6, one patient with Bloom syndrome. So really enriching for these kind of patients. This is also quite in line with data from the Japanese group published 2 years ago in Hematologica, where they also see that in the shortest telomere you see the TBDs, but in the shorter telomere also other inherited bone marrow failure syndromes. So I think it's really telomere length screening enriches for any kind of bone marrow failure. And finally, some data we have from our TBD cohort, what the patients look like. This is for 48 patients with good clinical data and genetic data. I just don't want to go through the whole table. Just here you see 5 patients we identified with the telomere length screening. They all had ATG cyclosporin treatment. None of them was responding. 2 also received Altrombopac, also not responding. And if you look for the clinical data, there's one patient with 20 years, the other were 40 and older. They had no family history, and only one patient had mild skin hypopigmentation, so there are really no typical signs for a TBD. So we identified them by a flow fish, and I think it's quite important since all these patients received unnecessary immunosuppressive treatment without any benefit for the patient. And with this, I'm coming to a quick summary. I think TBD represents still a clinically relevant but underdiagnosed subgroup within all patients diagnosed with immune-acquired aplastic anemia. I think the routine real-life screening reveals approximately 5% of confirmed TBD patients in adult patients initially diagnosed as aplastic anemia. This is quite also in line with what we see from other data from the NIH, from retrospective germline screening. I think FlowFish is a cheap, fast, and useful tool to screen for TBD patient and also to enrich for subsequent germline testing, just to see also not only for TBD but also for other inherited marrow failure syndromes. One thing is that telomere length testing is maybe less specific as a diagnostic parameter in older patients. What I mean with a diagnostic parameter, when you have a 10-year-old boy with a telomere length of 4 kb, this means something different than if you have a 50-year-old patient, of course. But I think it's still a valuable tool to trigger genetic testing in the patients even older than 40 years. And since we're having a debate here, I think it's also a question here to the audience, if a aplastic anemia patient with normal telomere length, if they should not get any further genetic workup or not that just urgent. And with this, I'm coming to an end, and thank you very much for your attention.
Thank you very much for this wonderful talk. Our next speaker will be Dr. Jill Dijon from University of Chicago, and she will make the case for selective genetic testing based on the low value of germline genetics in patients with newly diagnosed aplastic anemia.
Thank you so much, Daria, and thank you for inviting me to speak today. So this differential diagnosis has already been talked about at length, but for pediatric patients, about 85% end up being diagnosed with acquired forms of aplastic anemia, while about 15% end up having inherited bone marrow failure syndromes. And of course, there's a dilemma at the time of diagnosis. It's really important to know, are we dealing with an inherited syndrome or not? The preferred treatment is with a matched sibling donor transplant. But if that sibling donor is also affected and the patient has an inherited bone marrow failure syndrome, that's a big issue and something we need to figure out prior to actually proceeding with transplant. But many patients, most patients, don't have a matched sibling donor. And then at this time, immune suppressive therapy would be the recommended treatment. But if you have an inherited bone marrow failure syndrome, you're very unlikely to respond to that treatment. So as was mentioned in the previous talk, patients might be on immunosuppressive therapy for a long time. and ultimately still need to go to transplant. The turnaround time, realistically, for genetic testing at a minimum is 3 to 4 weeks, and sometimes patients incur significant out-of-pocket cost if insurance doesn't cover it. This can lead to delay in therapy, which is known to be associated with poorer outcomes for many patients who might have prolonged time with severe neutropenia and acquire infections, particularly invasive fungal infections, which might cause a lot of morbidity and mortality at the time of transplant. So we wanted to ask how many patients, pediatric patients with newly diagnosed severe aplastic anemia, actually have an inherited bone marrow failure syndrome, taking into account many of the studies that have already been presented. And specifically, what if that patient has a negative comprehensive workup? And what do I mean by negative comprehensive workup? And what was our hypothesis? So we actually hypothesized that there would be a low frequency of inherited bone marrow failure syndromes in pediatric patients who have this negative standard workup, which is very standard across the field at this point. All the patients included in our study had a negative chromosome breakage assay and a negative personal and family history. This was a retrospective multi-institutional study incorporating the institutions shown here. Patients were between 1 and 22 years of age. The majority were diagnosed in the last 15 years or so, but some went as far back as 2005. All patients met committed criteria for SAA, and all had a negative chromosome breakage assay, as I already mentioned. All had a banked sample and had consented to research at their local institution. We gathered clinical data in a REDCap database, as outlined here, and that was all entered by each local site, and then sent the banked DNA samples for whole exome sequencing at the Yale Center for Genome Analysis. We have a slightly smaller cohort than some of the other studies mentioned. We sequenced 153 samples, and ultimately 4 were missing data and were excluded, so we ended up with 149 patients who were analyzed, with a mean age of about 10 years, largely male, largely white, largely non-Hispanic. About 10% of those patients had telomere lengths that were less than 1% in either total lymphocytes or at least 3 lymphocyte subsets. And almost all patients had telomere length testing. About 38% had a PNH clone detected, and you can see patients had various types of treatment. So as I mentioned, we sent our whole exome sequencing to the Yale Center. We analyzed 102 genes via a custom pipeline in collaboration with Lucy Godley's lab at the University of Chicago at that time. Now she's at Northwestern, and filtered the variants, particularly to highlight genomic variants, and then classified them according to ACMG criteria. This is a comprehensive list of the genes we looked at, and very similar to gene lists that other groups have looked at. Of our 102 genes, we found variants in 52 of them. Total of more than 1,000 variants were curated. Largely benign and likely benign variants were found. About 5% were VUSs, and 6 total pathogenic or likely pathogenic variants were found in 4 genes and in 4 patients, and I'll just highlight what we found in those 4 patients. So the patient with a MPL mutation, of course, this is known to cause congenital amegakaryocytic thrombocytopenia with biallelic variants. She was a 12-year-old girl, no physical anomalies, no concerning past medical history. She had a known pathogenic variant, single base pair deletion causing a frame shift. The rest of her workup was negative, although she had a very small PNH clone. Treated with IST and had no response, and so she ended up with an unrelated donor transplant and currently is doing well many years post-transplant. So we concluded that she was a carrier for this pathogenic MPL mutation, but was not herself affected. A patient with FANC-C variants, of course this causes Fanconi anemia. She was a 4-year-old girl, again, no concern for inherited bone marrow failure syndrome. She had 3 insertion splice variants, 2 deemed to be likely pathogenic, 1 VUS. We went back and confirmed her chromosome breakage assay was completely normal, and she was treated with IST, had a partial response, but also went on to receive an unrelated donor transplant and is doing well. Important to note that She received standard conditioning and had no unexpected toxicity, so in our mind, unlikely to actually have Fanconi anemia, but we're currently trying to evaluate whether her 3 variants are in cis or in trans. We postulate that she likely does not have Fanconi anemia given her clinical course. Another patient with ERCC6L2, a 12-year-old who had a slightly abnormal initial presentation in that she had 5 months of progressive cytopenias before she actually met criteria for severe aplastic anemia, which in my mind is a red flag for genetic testing. She also had a negative family history. Here's her 2 variants noted on the schematic there. Both are noted to be known pathogenic variants, and she is doing well 8 years after a matched sibling donor transplant. Also, investigation underway to try and figure out if her variants are in cis or trans, but we postulate that she also likely is a carrier with these 2 variants in cis. The final patient had a SAMD9L variant. He also had an unusual story. An 18-year-old male, he presented with severe pancytopenia requiring transfusions, a known pathogenic variant from the St. Jude database that had been reported previously. And he actually did not have a negative history. He had a significant multi-generation paternal family history of cerebellar degenerative disorder. And while this patient himself had no neurologic findings, he was being followed by a neurologist. His case also was unusual in that his counts improved over a couple months so that he was no longer requiring transfusions. And the patient and his family decided they didn't want to get clinical genetic testing, even though their team had recommended it. He didn't want to proceed with any treatment, and then he was ultimately lost to follow-up. So while they did consent to research, they did not consent to clinical genetic testing. And I think this patient would not have been a misdiagnosis if he had actually complied with the treatment and testing recommendations. So he clearly has ataxia pancytopenia syndrome. So to summarize, a somewhat smaller cohort, because we're talking about pediatric patients. We had a total of 149 patients we studied. 145 of those had no pathogenic variants identified at all. 1 was a carrier. 1 had ataxia pancytopenia syndrome that would have been identified and hence probably wouldn't have been in our cohort at all. And 2 with multiple variants, but we postulate are likely carriers. So we found a very low frequency, arguably approaching 0 in our small cohort of patients with inherited bone marrow failure syndromes who had a negative workup. The comprehensive workup, it appears to be very adequate for trying to rule out patients who might have an inherited bone marrow failure syndrome with a low threshold for then recommending genetic testing. The issue is that the delay in treatment that is currently necessary to work up the patient and potentially also their sibling donor puts patients at risk for infection and also potentially causes large out-of-pocket financial cost for families. A faster turnaround time and better insurance coverage are things that would be recommended for these families. And with that, I'll just thank my collaborators. I want to especially call out Melissa Gavaria, as she is a fantastic undergrad who did about half of the variant curation with me. Thank you.
Thank you, Dr. de Jong. It was really refreshing to hear the pediatric perspective. I anticipate there will be lots of questions at the end. So let's move to the last speaker of the session, Fernanda Gutiérrez-Rodrigues from NHLBI, who will talk on clinical predictive factors to differentiate acquired aplastic anemia from inherited bone marrow failure.
Oh. Okay. Thank you, everyone. Good morning. Thank you, the organizers, for inviting me. And I think my talk is going to be a nice summary of all the previous talks, and I hope that we can kind of like discuss a little bit better like at the end. Let me see how this works. Okay. So once you have diagnosed a patient with bone marrow failure, the question is this inherited or immune? So we have heard about the importance of genetic testing to identify cases of inherited etiology, and the immunoaplastic anemia is usually a diagnosis of exclusion. So there are many genes involved in inherited marrow failure, and the genetic testing is not available for all the clinics, especially in countries like in developing countries where this is a very costly assay. So here, like in the lab, we try to create a tool that could help us to identify some patients that could like benefit from genetic testing. So our questions is, what if we could identify these cases, especially those with non-classical inherited marrow failures? As we saw Lisa saying, some patients do not have the clinical, like the classical clinical manifestations. They are not suspected to have inherited disease. And more importantly, what if we can identify these aplastic anemia patients that have immunopathophysiology so they can start immunosuppression right away? So for this, we develop a machine learning model. So we use machine learning to try to identify parameters that could help us to identify these scripted cases. So we used data from a cohort of more than 300, actually approaching 400 patients, which include, and we also included in the models, all the clinical variables that were available at diagnosis. So we were able to come up with 30 different variables. And when we created the model, a big surprise for us was 27 out of the 30 variables were important for the differential diagnosis of marrow failure. You can see in the graph bar that the top predictors variables. So the top predictor was telomere length measurement, following what FABIAN told us in the TBD patients. But the second one was isolated abnormal cutaneous findings and also long-standing cytopenias or macrocytosis. Then we have sex and age, and we also have CBC from the time at diagnosis. So the results of this machine learning for us didn't tell us anything like super novel, but it was a nice way to map and to kind of like standardize what are the clinical parameters that is important to be taken and collected at diagnosis, which that needs to be very comprehensive. So the first one that we're going to talk about is the age, as Lisa said in her talk. So in general, young patients presenting with marrow failure are more suspicious of inherited disease. On the left, you can see that bone marrow failure patients with immune etiology, they tend to be older than an inherited cohort. But you can also see that basically you have adult patients also in kind of like both groups. And you also see the aplastic anemia, we have a bimodal distribution. So that's important to take in consideration. So although age is an important factor, this shouldn't be used as a definite cutoff for further workup. Second thing is the evidence of multi-organ involvement and a history of hematologic and solid cancer. So these are very suspicious for inherited etiology. Many cases of immunoplastic anemia is an acute and isolated process, and the main exception for this is the post-hepatitis AA. So the fact that we see multi-organ involvement leads us to suspect an inherited etiology. Family history is also very important, and again, a history of hematological disorders, solid cancers, or any other like multi-organ involvement, because this leads us to think that this is an inherited disease. However, we still have to consider that many inherited marrow failure can have variable penetrance. The variants can be de novo, or the germline variants can also be associated with recessive disorder, meaning that many parents and other family members, they can be clinically like not affected. And another point to consider also is the duration of cytopenia. So often, inherited marrow failure will have a slowly progressive, moderated cytopenia, while the severe aplastic anemia, like where immune cases, they have a very severe pancytopenia, like rapid drops in the counts that we see, followed by like the severe cytopenia. And finally, the last clinical point that I wanted to mention is the evidence of immunodeficiency. Some inherited marrow failure, such as GATA2 deficiency, you do have evidence of immune dysfunction, while the immunoplastic anemia, the infection risk tends to be related to the degree of neutropenia. So altogether, you have this kind of like main topics clinically that could guide us a suspicion of inherited disease. But we also have to consider that the model required the 27 variables, which included telomere length and also included some CBC. And also, we used it for the model, like patients were negative for Fanconi, like DB test was also very important to this. So I wanted to highlight here the importance of telomere length. So the accuracy of the model without telomere length was much lower. The model did not perform well. And the model did not perform well also for pediatric cases. Another point also that I wanted to make is we did not include in this model the PNH, the presence of PNH clone, because for the model, to create a model, we need to have all the variables available for all the cases. And we do have a bias for PNH for the cases that are suspected, very highly suspicious of inherited disease. Usually these patients are not tested for PNH, so we are not able to include this variable in the model. So overall, the model identified 89% the cases correctly, 92% of immune cases, and 79% of inherited cases. Actually, when we disconsider the patients that were suspected of inherited disease but had a negative genetic testing, the model was able to identify 98% of the immune cases correctly. And here, we try to come up with a strategy for not using the telomere length measurement, but was really difficult. The only thing that we can say that is that when telomere length is missing in adult patients, because it's where the model performs well, we can see that adult patients with severe aplastic anemia rarely have an inherited disease when they have no family history or no clinical manifestation suspicious of inherited disease. And the specificity of this goes up to 100% when we use PNH, presence of PNH as a variable also for immunoaplastic anemia. And this is kind of like what we know, right? Clonality can be very important for the differential diagnosis. PNH and 6-PLOH are specific markers of immune marrow failure, and this is a work from Dr. Babyshock group. PNH and 6-PLOH has a positive predictive value of 100% for immune versus inherited, but the absence should not be used to exclude immune in the etiology. And also sometimes some patients, they have somatic data, and what we have been seeing is that the somatic data can also tell us a lot about the underlying pathophysiology because they are clonal signatures specific with some inherited disease. So in the history of our clinic, we have seen only 3 cases of patients that had a PNH clone and a germline variant that was suspected to be causing an inherited disease. So the first one is actually a patient from Rodrigo Calado in Brazil. So the patient had a third germline variant and a PNH clone of 6%, a 20-year-old male with moderate aplastic anemia, very short telomeres, family history of pulmonary fibrosis. We were very sure that this was kind of like a telomere disease before the PNH came positive. And this is because although the variant was novel, there was another one pathogenic in the same codon that was classified as pathogenic with a functional activity showing that the variant reduced 50% of the telomerase activity. So now we don't know exactly, because this is a very complicated case because it's not a small PNH clone, is 6%. And the other 2 cases are patients with DDX41. This is the first one is a second opinion. Was a 77 years female with severe aplastic anemia, a variant of the M155, and a PNH clone of 13 that during follow-up and treatment went up to 39%. So this was a work published by Dr. Murnau Patnaik group. They screened a large cohort of DDX41 patients, and the same variant, this methionine 155, was seen 5 out of more than 4,000 patients. So it's a rare variant, but in all the cases were considered VUS. They did not classify as pathogenic. And the second one, a DDX41 in a different codon, and a 12-year-old male with mild thrombocytopenia. He also had a PNH clone of 3%. Family history, the mother was also affected, and the variant segregated with the disease. So we also were sure that this was kind of like a DDX41 case before the PNH test came back like positive. And the same thing, the DDX41 in this patient was also considered a VUS, seeing only 2 cases of more than 400 patients, DDX41 patients tested. So I think in these cases, it's difficult to confirm the diagnosis of inherited disease, as the variant can be pathogenic, but maybe with a variable penetrance, or maybe it's a benign variant and not related to disease. So either way, we only have 3 cases out of many that we have been seeing for many years at NIH. So in conclusion, the clinical manifestations and also the clinical tests are important for the differential diagnosis of marrow failure. We see that we are more likely to identify correctly the cases with immunoaplastic anemia than those with inherited. So unfortunately, genetic testing is still important. So only with genetic testing, we're able to identify around 50% of cases that have no clinical suspicion for any inherited disease. Thank you.
Thank you very much to all of our speakers for wonderful talks, very thought-provoking. We would like to now open our floor for discussion, and so we would like, of course, questions from the audience, but also a little bit of maybe discussion between the speakers. Okay, go ahead. Yes, please.
Great talks. I'm a little confused at the end. So if we're going to do genetic testing, because bone marrow failure, because the incidence is 3 to 5%, as you said. No. If we're going to do genetic testing on all patients with bone marrow failure, because the incidence is 3 to 5%, as you suggested, do we need to do telomere testing if we're going to do that, if we can get it done rapidly, for example, because telomere testing is not always fast either. So that's my question for the moment.
I think I can answer. I know that I was supposed to advocate for no genetic testing, but I think I had to do my job correctly, I guess. So this was kind of like one of the main points in discussion of when we come up with this machine learning model, telomere length is important and should be included in the routine as if DB test, as if PNH testing. So it costs less than genetic testing. So it may be a priority if your service doesn't have either one or the other. Maybe telomere length should be the one you should start off. But we also need to understand what is the reality and sometimes what can be implemented first. Let's say this.
If cost was no factor.
I would say both.
But telomere length testing is rapid usually. I mean, you can get a result back within a few days in contrast to genomic testing. I wanted to just, Fernanda's talk was clear, but I wanted to add my own thinking about the issue of inherited or constitutional aplastic anemia versus immune, because the problem isn't really with the model, it's with the heterogeneity that is in the inherited population. And we have a deficit in the number of Runks and Fanconi cases. But the heterogeneity is there. Those individual syndromes differ from each other far more than exists within the immune category. The immune category is surprisingly homogeneous, as I've advocated. I think immune aplastic anemia is a separate disease, whatever the genetic factors might be. And ultimately, with the app that the NIH is now hosting, we should have more cases eventually that are pediatric that would allow a clearer distinction so that the cloud will look not so much immune versus inherited, but immune versus Fanconi anemia, clearly telomere biology disease, clearly Runks, and so on. So the problem's not the machine learning. The problem is the data that go into it and the biology, which is that Fanconi anemia is not telomere biology disease, is not Runks 1, and so on.
Yep, I have a question in terms of the DDX41, so that we do find DDX41 germline variants in patients with cytopenias. The biallelic cases are usually the leukemias or MDS. Now you found these 2 cases with somatic hit, and this somatic hit has been described in other leukemias in the context of also being biallelic, yet you say that the VUS. I mean, I think that in terms of the somatic hits, the VUS classification has to be, I mean, really a subject of common sense, right? Rather than just saying this is a VUS, but there were 5 patients with leukemia with biallelic inactivation of the very same gene. In this context, yet I call it VUS, as if it's unclear what the meaning of the variant is. What do you think?
Okay, I think this is the case that I presented. So both cases were germline mutations, so not somatic DDX41.
The VAF was very low, what you have shown.
What do you mean?
The DDX41.
No, so the patients were heterozygous germline variants for DDX41. The frequency that I showed there was not the allele. It was like 2 patients out of 400, 4,000 patients that were also fine with.
This was variant allelic frequency,
yeah,
not
no,
the.
No, it was very like it was just the frequency of that particular germline mutation in this large DDX41.
And again, these cases have been found among patients with leukemia in a context of biallelic inactivation.
Yeah, I think.
So how they are VUS? Again, common sense.
Yeah, I think that the paper, what they described was that they didn't have enough cases to say that they confidentially that they were pathogenic. I think that we are not experts. I am not expert of DDX41, but in our case, whenever we see a variant like this in our lab or in our hands, we try to go to the literature and see if there is anything there, if this has been seen in other cases or not, and how the experts are dealing with that. I think that the only thing that we saw is the variants were seen there, they were present, but they didn't handle, I think there was another paper that one of the variants were considered pathogenic. So the thing is, what should we do, right? It's pathogenic or not, VOS or not, but in our hands there was a PNH clone. So I leave this to the physicians to make their call.
Thank you very much. There was a question in the front.
Yeah. Okay. Thank you very much. I really enjoyed this session because it was able to change slightly my view, because in the very beginning I was on the side genetic testing for everyone. But then when I listened to the presentation, I said, maybe. Because Neil pointed it out. I'm a pediatric hematologist, as you know, and the heterogeneity of the constitutional marrow failure is incredibly high, and particularly in the field of the telomere. We recently discussed a case internationally with Rodrigues and others of a patient with a clear phenotype of telomere biology disorders, telomere below the first percentile, no gene. And what shall we do? So, and this is easy found by anyone in clinical practice. So my idea would be, we have in our institution a system that fortunately is called fast track. When you have some suspicious case, you can get the return of the response in 10 working days, which means 14 calendars. My idea would be to apply, definitely, no doubt, and we learned from Fabian that may also be no telomere biology disease genes in telomere short patients. So that increases the confusion. So what the message I got here is that, okay, we should do genetic testing for patients within the area of telomere biology disorder, given that you may have also a pretty normal patients. We know from classical historical data from Neil's group that third and third patients may really look like acquired aplastic anemia with no other symptoms, with no fibrosis, with no slowly appearing. So that, my view is anyone who sees the smelling area of telomere biology, that should go genetic testing along with the TBD. And sorry, I was being long, but a question specific for Fabian. So you show, I know because we've been working together for so many years, but you show telomere in length in granulocytes and in lymphocytes. Classical literature says that you have to do that in a number of subpopulations of lymphocytes. You still go on, and you rely most on the lymphocytes length when you make a diagnosis. Reason why you still keep on doing that on granulocytes, is that because you won't have kind of coherent judgment, more robust conclusion in doubtful cases?
I think that first, when we run the telomere testing, we get all the data at once. So we get also a lot of 6-panel telomere measurements now for the aplastic anemia. You always get also the results from the granulocytes, or you have to interpret it. So if you have a patient with typical autoimmune-acquired aplastic anemia, we frequently see that the lymphocytes are still maybe in a lower normal range, and then you see like a drastic shortening in granulocytes. It's a typical image we see for MDS, and immune-acquired plastic anemia patient. So then the granulocytes also really helps you to make it more solid, that you said. This might be an autoimmune related, and that's why I love a little bit the granulocytes, because it helps you for like myeloid clonal disorders.
So I just wanted to say a practical approach to this. You emphasized, thank you so much, of the importance of not taking forever to make this diagnosis. One thing that I've found in looking at many of these patients is that a number of individuals and centers get stuck with the notion of genetic testing, and 4 months later, when their patient has had multiple invasive infections, they're still thinking about it. And so I think this type of a discussion is so important, because what we have to do is combine clinical factors and some of the things that really do say this is an autoimmune illness in order to make these diagnoses. Now, this really nice presentation has brought out the importance of telomere testing. So here's a question. You said how many below 10% are there, but how many of those below 10% have a disease? And how many of those below 10% who have no clinical manifestations and have a disease, or family history and have a disease? That's the type of thinking that I'd like to see in this. And so can you please comment on that? Should we be sending a genetic testing on 100% of those patients who have telomere screening and they're below 10%, or should we only test those below 1%? What's best, and making this so that we can get these workups done in time to treat the patients before they're harmed?
I think that's a really hard question to answer. I think for me, first, when they're really below the first percentile, that's also, I think when they're really below the first percentile, it's always worth running a genetic testing. We normally try always do it at once, like starting both together. So you really have to, the telomere testing really get you quite early. We have it within 2 weeks. That's normally pathologists take 1 week until you get the marrow, and then you have another week to start treatment, and you have the telomere results. And if they're really short, yes, it's worth waiting for the the germline testing. We have, I think for in general, like when you look at germline testing, it's always nice when you get a pathogenic variant, so likely pathogenic, then the case is quite clear. I think telomere length testing really helps you with the VUS. I think that's the major problem we're dealing when you have a VUS. How to interpret it is somewhere in between. Yeah, we do quite. We in our department, we run, if it's not typically really far below, since we also have the 6 panel, and we start regular treatment. What we stick to the patients and try to get the genetics done. So if they're not responding, for example, and then and 3 months later you're in the need for transplant, then I think you have everything set up, and then really can then also like a patient-tailored transplant regimen.
Okay, so this was a very exciting panel, because it's 20 years or so of the telomere disease history in a nutshell. Especially because if we look backwards, the prevalence that Fabian mentioned, about 5% patients with mutations, is exactly the same that we found in 2004 with only 2 genes, TERT and TERK. And the patients were not screened. We had only Sanger sequencing at the time. But what happens here is that now clinically, and what Michael just said is very important, clinically we are able to screen these patients from the clinical history and the physical examination and sort them out. And these are the patients who are still there. So the major issue that if we can combine all the talks here is that when we do that in a larger population, the positive predictive value by law is lower, because you reduce the prevalence of these patients in the general population, and then you have more of the certain cases. And Fernanda illustrated that with a few very complicated cases, and since we now have NGS, we have a lot of VUS also that might be very complicated sometimes to tease out whether that's pathogenic or not for the patient, and especially for screening for the donor to exclude or not the donor. So that's a very difficult issue to deal with. So when we try to, specifically based on the data that you all presented, when we try to specifically sort those patients who are more likely to have a potential inherited syndrome, this makes it easier to interpret the data. That is still working on that in terms of interpreting the VUS cases and give faster the results for patients and not let them with a fungal infection for a long time waiting potentially for a transplant when we pretty much know that it's an immune case. So my interpretation from what you all said is that when you focus on those more likely to have an inherited disease, the diagnostic, the predictive value of the diagnostic tests are going to be more important from the clinical point of view. Yeah, sure.
Actually, we have, sorry.
But
we have four
it
people
exaggerates
waiting at
one
the
thing.
mic also.
Exaggerates the value if you test only people who have short telomeres for the variants, and now you have a VUS and a patient with short telomeres. Well, then you say this VUS is suspicious, right? I mean, we call it suspicious VUS. But then you didn't test these people who didn't have short telomeres, and this VUS was present there. So now your VUS is suspicious in the context of short telomeres, but your VUS is not suspicious in the context of not short telomeres. So in other words, if you bias it strongly and you skew literature forever, if you test only the ones that you think are suspicious, and how many people with with short telomeres run here around and don't have aplastic anemia, right? So I think it's a conundrum that, you know, the recommendations that are being made and presented here are very inadequate.
That is a very important point that Dr. Majewski made. Okay, so we will, in the interest of, we have 3 questions that I would like to address. We have Dr. Savage, Dr. Patel, and a doctor at the microphone. Maybe with Dr. Savage first.
Thanks. So I think everyone probably knows what I'm going to say, but actually, no. I think this is an opportunity for this field, for these patients, to start looking at the parallels with cancer genetic testing that we do in the oncology clinic now. So if you look at children with cancer, any kind of cancer, children with cancer have a 5 to 10% likelihood of having a germline predisposition syndrome. That number is roughly what we're seeing in these aplastic anemia patients. There are no doubt there are those who present who are clearly acquired autoimmune, like those are the no-brainers. Take them to transplant, fix them right away, right, if they're kids. But I see no reason to not send a gene panel at the same time you're doing all this other testing for exactly what Dr. Pulsifer already said. You don't want these people running around and being delayed for 4 months before you decide to do genetic testing. I will, though, also just say we haven't talked at all about genetic counseling, and that is also something that we can't underestimate the effects this has on the families as well. So I think these programs, we need to sort of think more holistically about how we're going to incorporate that whole concept of genetic testing, of looking at the VUSs, as we also talked about, and kind of thinking about putting it all together.
If I may just add to your statement, so I think it's also all about the urgency, right? Many pediatric or adult, also hem-onc doctors think, it's aplastic anemia, it's not that urgent as leukemia. Now, I always look with enthusiasm at pediatric neonatologists who are able to get whole genome sequencing done within 36 hours and report 100 genes for the very sick kids, you know. So why can't we do that? Okay. Next question.
Hey, thank you. Nick Hypers, Medical Director with Novartis, also known as Dr. Microphone. My question is for Dr. Jong. So I was just wondering, you reported about a 38% of the patients that you saw had a PNH clone. Did you see correlations between the presence of those clones or the clone size with telomere length?
That's a great question. We've not looked at that. I definitely need to dive down a little bit deeper in exactly the clone sizes. Most of them were very small clone sizes, but some of them were larger in the 1 to 10% range. And we've not compared that with telomere length size. So that would be a great thing to do. Thank you.
Thank you.
My turn. So again, I'm a clinician, so practical question. Dr. McReynolds, in an unselected aplastic anemia patient population, showed that the unrecognized germline predisposition is about more than 5%. But then Dr. De Jong, you showed that it was less than 1%. So is it correct to say that if there is a patient who does not have clinical manifestations, no family history, and if you have the availability of the telomere length and the DEB, the severity of blood counts could be one of the biggest decision-making as to whether or not you send the genetic testing, but more importantly, whether you wait for it to treat?
I would certainly advocate, part of the comprehensive workup is to send everything, and I'm absolutely an advocate. At our site, we send genetic testing on everyone. All the sites that participated in our study send genetic testing on all their patients. And the concern, as we've brought up, is just the delay in therapy. And often what happens then is how it impacts looking at the sibling donor. So you get the results back, and just realistically at our center, it's 3 weeks would be a great turnaround time. So sometimes it takes longer than that. And if you're doing cultured fibroblasts as opposed to bone marrow or peripheral blood, that also takes extra time to culture the cells. So there can just be a big delay. I'm an advocate of sending the testing, but then you have to be really savvy with how you're interpreting the results, especially with VUSs. And I don't have all the right answers, but there's evidence that patients can do very well clinically with unidentified genetic results.
And just to add to this, I think that we also need to make clear that pediatric population is different from adult. I think at least for our model, we know that the pediatric cases, there was a lot of cases that the machine did not pick it up, did not predict correctly. So we definitely need to do something focused for the pediatric population, because an adult population, it looks like that is a little bit more clear. I started saying the immune A is a diagnosis of exclusion, but actually based on our data and our model, is actually not the exclusion, is the inherited cases. So in adult population, it looks like the immunoplastic anemia is a much more homogeneous cohort. You're able to identify this more clearly, and everything else, it's kind of like genetic testing, could be inherited.
And I'll just emphasize, my cohort is significantly smaller than a lot of the other adult cohorts. We only have 150-ish patients. Yes, and also very selected.
Yeah, this is exactly what I was thinking. This is the main message in the end, and I think as a community, we have also to deliver clear messages for those who don't have access to genetic testing at all, or quick genetic testing. I mean, if you look to your cohort, it's very informative. We have 150 patients. They are all severe or very severe. They have no family history. They have no morphological abnormalities. The disease is quite quick. I mean, it's not something for long. And in this particular population, you find 6 cases. And if you look into the 6 cases, in the end, it's just because we didn't ask the family. You are finding something. So just to say, I think that we need to educate the other physicians also with this, because we are jumping on genetic testing because this is fancy sometimes. We like this. I mean, this is sexy. Well, I'm going to do genetic testing. But in the end, we might decide for our patients on very simple things. And we should come back to this sometimes, because this is very informative, and just not making patients delaying treatment for nothing. So thank you very much for this.
And I think Michael's point was not that physicians wait 8 weeks to do genetic testing, is that they get hung up on a variant of unknown significance, and that's where the delay is. I mean, it's interesting from an epistemologic and other, the world is big, 10% of people around, have short telomeres, and they don't have disease. And a DDX41, I don't know that that's causing leukemia in everybody who's got, that 2% or 1% in the general population. It's very dependent on other genes, it's very dependent on penetrance. So I think there's an overinterpretation, both quantitatively and qualitatively, of genetic testing. So practical data that have been presented here are really important without getting fixated on, oh, there is a variant that might be important, and therefore this patient has CDX41, and the whole family has to be screened, and we have to go to a specific therapy, or the telomere length is X, and therefore the patient has Y. So I think there are deeper issues in terms of how we interpret big data and complicated genetic information. Sorry.
Thank you very much for this point. So I would like to close with one quick question to Dr. McReynolds. So if we were to send genetic testing, what type of genetic testing should be sent, in particular in regard to copy number variants, panels, whole exome, which genes?
Yes.
In 1 minute.
In 1 minute. So that's a big question, especially in 1 minute. So I think, in an ideal world, right, we would send everybody's long read whole genome so that we could get really great quality CNVs, SNVs, and all those things. In the real world, I think, panel testing that also includes coverage sufficient enough for CNVs is really important. We miss a lot of the Fanconi variants and others if we don't look for the CNVs.
So if I can make one real world comment, this is Stacey Arnold, Emory University. I appreciate this vigorous academic debate, but in the real world, if the insurance doesn't cover it, we can't get this testing. And so we've greatly have benefited from your contributions to the science, but we still have these questions. And so I think the next step is, what's the next study, what's the next publication, so that we can advance that, so that then in the real world we can actually do what's best for our patients.
I could not agree more with Dr. Arnold on that, and because we get a lot of referrals from patients who are unable to get genetic testing who truly need it. And I think we can serve as an advocacy point to get it covered, right? Because if this was a breast cancer patient in your breast cancer clinic with a 5% risk of a BRCA variant, you would get the testing, right? And our patients have a 5% risk of a genetic cause of their disease, and they should get the genetic testing. And two, to advocate exactly what Marcin said, we know that we can get an exome in 36 hours on a neonate, so why can't we get it on our patients off a skin punch that came from your bone marrow biopsy at the same time? So anyway, my last 2 cents.
Thank you. Thank you all to the speakers. We will move on to the next part of our session. So our next speaker will be Dr. David Sykes, who is coming from Massachusetts General Hospital, and he will start off on this session about genetic discoveries that are informing our understanding of aplastic anemia, pathogenesis, and also informing potential new treatments.
Sequencing, we'll touch on the child to adult transition. We'll touch on delays to transplant, and then I also want to give a little preview. Then actually, it's nice because I think later today you'll hear a little bit about a clinical trial which has just come out, and a talk this afternoon about JAK inhibitors and bone marrow failure. So with that, let's get going. So this was the paper that came out about a single patient that I hope informs a little bit more about aplastic anemia biology. A bit of a shout out to Rob, his surgeon, who mentored the pathology here. And I think actually our first author, Jake Rosenberg, spoke to Dr. Jong a couple of times about this along the way. And this also came out of a sort of a fun, to the point of not everybody can get exomes and not everybody can get testing. This was part of a program at the Mass General Hospital, which was kind of a research program and gave residents a chance to dive into a particular case and gave them some extra resources. So this was a gentleman, we got a phone call, high school, and he was missing high school because he was in the emergency room getting blood transfusions. And what could we do? So he came down to see us. As you can see there, hemoglobin was quite low. His ANC was around 500 and nadir at 200, and his platelet count was pretty preserved, actually. And he gave a very interesting story. He'd always had these mouth sores, and he thought nothing of it. His dad had mouth sores. His grandma had mouth sores. He took some prednisone, and they mostly went away. And he was really unperturbed by these. This was sort of common in the family, but at this point now he was very anemic. And he was very, very thin. We're still not entirely sure if that's part of that. And he had thrush, and quite impressive thrush as an 18-year-old. The bone marrow biopsy was hypocellular, but not strikingly hypocellular.
And what was quite striking at this point was in the family history. And after he told us, we sort of put it together, you can see that, of course, there's the patient on the bottom and his father. But interestingly, he had 2 half-brothers that both had the problem, and then traced it right back to his grandmother, who had passed at the time and had grown up in Puerto Rico, but also everybody with these mouth ulcers and a lot of thrush in the family. So we were very lucky as part of this program that we could just get whole exome. Now this was a research exome, so then it had to be confirmed with the clinical Sanger sequencing. But this very rapidly identified a STAT1, and in this case was a known mutation in alanine to varanine, which was a known gain of function. So that was helpful in teasing out why this looked like an autosomal sort of dominant inheritance pattern. And as I said, this was not a known mutation and really not a known syndrome, but a bit of a rare manifestation. So I think most of patients with STAT1 gain of function, and I'm not an expert in this, but looking around on all the published literature, most people had autoimmune manifestations, but very few of them were actually cytopenias, and really very few were aplastic anemias. Most patients, as you can see, almost 100% had this mucocutaneous candidiasis. The patient was a known mutation, as I said, many known mutations in STAT1, even though it is very, very rare, still people have been well studied. I will skip the simplified JAK signaling. But so in the literature, there had been case reports and even small case series of like, okay, can we quell down, which is presumably this T cell attack on the bone marrow from overactive STAT1 with a medication such as ruxolitinib? And so this was nice, and actually one of the authors had even been at Children's Hospital, Katja Weinock, who's now at Stanford. So with that in mind, we're in discussion at least, and due to sort of unfortunate social reasons, we were having trouble getting him to transplant. It turned out his brother was actually a perfect match. And so we were in this weird quandary, high school student, could we transplant? And so after multiple issues for febrile neutropenia, and we were really pressed to do something, we wrote a single patient IRB. And it just happened that Eben Chen at the Mass General Hospital had been doing a GVHD study with itacitinib, a JAK1 inhibitor. And so we had sort of a discussion with the company, Insight, and they agreed to provide free medication for this gentleman. And so he was started on itacitinib. And what's really striking, and it's actually kind of unbelievably striking, is he just kind of got better. He got better within a week of starting the medication. He stayed on the medication for almost 2 years, but it was just striking. The red cell response, and particularly the reticulocyte response, was just dramatic. His white blood cells increased. His bone marrow didn't get that much particularly better. His platelet count was sort of always in the low hundreds. But what was really nice is that he was able to kind of get through this period of his life, finish high school, was no longer, and his mouth sores got dramatically better. So it really seemed like the whole syndrome for him, which was mostly thrush and mouth sores, was much improved. So what was, and I guess I'll skip this is just a summary, but what was sort of important here is that Jake Rosenberg, the first author on that paper, had really spent the time collecting samples and going through getting these longitudinal samples before treatment. Every time he came into clinic, we'd get a sample. I'm just showing here the kind of concept that we then worked on, which was this bias in T cell differentiation, which actually may or may not be the case. I'll let you know. I'll let you guys see what you think, because we actually saw much more of a monocyte effect with a STAT1 gain of function. But the idea being that we have a dysregulated T cell because of this overactive STAT1. And I'll make a plug here for the importance of banking cells. We got into big trouble from the IRB because we exceeded the volume of blood we were supposed to take. So that was my first experience being called into the IRB's office. But that being said, we had a lot of blood in the freezer that we could do studies on. And so Jake went to Stanford and he did some phosphocytoph, spoke to Dr. Jong, and we had some results here. So as I said, the T cell data you're going to see is not all that striking. This is now monocyte data, and you can see in the pre-itacitinib orange, you can see that the phospho-STAT1 is indeed higher and is reduced by itacitinib JAK therapy. That's the blue, but not down to the level of healthy controls. We did see a decrease in plasma interferon. This is by Luminex, so this is kind of a relative quantification. That seemed to go well with the theory, of course, that we had a cytotoxic T lymphocyte. And now this is where things get a little confusing, but I think it will make sense. If you look down on both the orange and the blue, you can see that the T cells don't make as much interferon. Now you're saying, well, what the heck? It's got to be coming from somewhere. But remember, this is now T cells that have been taken out of the body and stimulated in vitro. So we're going to argue for an exhausted T cell phenotype, and that those T cells, when they hit the tube, are now no longer able to make interferon, though they've been making interferon and they're exhausted in vivo. So those are your CD4 cells, your CD8 cells, so very similar phenotype. They're not making as much interferon. But look at the now PD-1. And so I think here we've got the sense that, okay, the T cells look like they're chronically stimulated. They have high PD-1 expression. They had high other markers of exhaustion. And that did seem to be quite nicely reversed with itacitinib. Like I think you'll hear more from this afternoon's speakers, and probably Dr. Dulatov did some single-cell RNA expression, which was also quite telling. Again, a lot of interesting stuff in the monocytes, which I won't have time to get into. But again, even the interferon gamma expression at the RNA level, you can see, did not go down significantly. And so we were going to argue, and Jake was arguing for sort of a post-translational defect. But really what was, I think, most striking on the left is that exhaustion concept, and on the right is the cytokine effector score. All of those, of course, are these gene sets which are in the supplemental. But you can see it does look like a significant decrease in T cell exhaustion and a significant decrease in cytokine effector score. Okay, the monocyte data, as I said, was probably the most striking. And it turns out the idea being that maybe this chronic stimulation of the monocytes then feed forwarding on the T cells was part of the process. And then one other just quick slide that was a lot of work, but just to show a quick ataxi, there was a reversal of the occupancy at the PD-1 locus, going along with the reversal of the expression of PD-1 and hopefully the reversal of T cell exhaustion. So that's a bit of a whirlwind through a ton of data by Jake, just to say that it looked like the STAT1 gain of function led to an expanded, activated, and exhausted T cell, a lot of activity in the monocytes, and they did seem to be reversed with itacitinib. Okay, so the question is, of course, is this just a cool story, and this seems inapplicable, but I think what I'd like to make the point for, and I think speakers this afternoon will make the point for, is probably more than just STAT1 gain of function patients have an activated, inappropriately activated STAT1. So with Dr. Surgeon and Lucas Mathoth, who was a resident at that time, basically we went through and looked at a handful of normal bone marrows and a handful of aplastic anemia patients. And if you stain normal bone marrows with phospho-STAT1, there on the bottom, you should not see any phospho-STAT1. And we did not see any phospho-STAT1. And then if you stain patients without a STAT1 gain of function mutation who have aplastic anemia, look at that. In this case, at least, we had 1, 2, 3, 4, 5, 6 out of those 10 samples that had detectable phospho-STAT1. Now, once you know it, it turns out that this is not only in humans, and this also, you'll see both the first and the last author there. We'll hear more from them, but this also turns out to be the same kind of concept in preclinical data mice that was published shortly thereafter. It turns out that just hot off the press, we have a clinical trial that's just opened at the NHLBI looking at ruxolitinib. We can give you the big saga of why it's not itacitinib, but many discussions with the company. But sort of a cool, and hopefully this will shed some new sort of insight into a functional marker and maybe even phosphostat staining on a new treatment for aplastic anemia. So a huge thank you. Thank you to our medical illustrator who put together that pretty cover there, and appreciate the invitation to come speak. Thanks very much.
Thank you very much. The floor is open for questions. Any questions for Dr. Sykes?
The mic's coming. Hang on a second.
I know we're trying to catch up on time, Dr. Babushak. That's good.
It's a wonderful case and very instructive clinically. But if you then look at the number of these possibilities that these mutations are actually unfound or maybe a less virulent variants of STAT1 in patients with aplastic anemia, if you then screen broadly patients with aplastic anemia, which I am sure you did, but we did as well, and you don't find any anymore. So in other words, it's a wonderful case that illustrates the role of STAT1, but as etiologic factor or genetic factor for garden variety aplastic anemia, do you agree that it is not the genes that we would implicate?
I would definitely not look for STAT1 variants. I think Jake and probably myself would have you stain for phospho-STAT1 on the bone marrow. That's not a clinical stain, but as a functional marker of an inappropriately activated T cell, and maybe as a functional marker, you could throw in some ruxolitinib while you're waiting to get the patient transplanted.
Yeah, but you know, I mean, if you stain for any other activated T cell marker in aplastic anemia bone marrow, you find it high too. So
that's true.
So
I think it was more the and certainly, please, and I actually am not a pediatric bone marrow failure person, but boy, the JAK inhibitors are all over, and for autoimmune diseases, and I think when we were talking about, do you hit somebody with ATG? Do you immediately take them to transplant? We got an answer within a week on whether the JAK inhibitor was working functionally. So if you took your patient and gave them a couple doses of ruxolitinib and they got better, well, you could actually calm down. Do your transplant in 4 weeks or 6 weeks. I mean, we had these. He was on the medication for 2 years, and then he came off, and then he relapsed, and then we transplanted him. They do have to work. No, but it's an open field. It's actually, but the speed and the kind of the ability to calm down both the doctors and the patient and feel better was quite striking. So no, please don't. I'm not going to get on a podium, but I'm just like, interesting. Maybe we should give it a try. And the downside seems very low. Thrombocytopenia, obviously, in patients who might already be very quite thrombocytopenic. Please.
Thank you very much. Fascinating story. So going back to the basic science, what is the evidence about STAT1 pathway within the immune cells in aplastic anemia? Before treatment, after treatment, Th1, Th70, TR1, and blah, blah, blah.
I'm actually hoping this afternoon speaker talks about that, which I think they will. So let's stay tuned. Yeah,
okay.
Because I don't pretend to be a STAT1 expert.
Thank you so much. We have two.
Yes, I'm coming up.
2 questions.
Go. Yeah, hopefully this afternoon we'll get some more insight on exactly that.
There was a question right in the middle.
Yes, thank you.
Oh, that was very interesting. You're lucky to have that service that can quickly screen. So you shared that this particular mutation is associated with other immune deficiencies, but has actually not been reported previously with aplastic anemia. Do you have any insight as to why this particular variant has any relevance to the phenotype that you saw? I know this is a speculative.
No, and I love that, because you're right. This is a bit of a one-off. And since we had whole exome, we did have a chance to at least look at the other genes to see if there was a cooperating mutation. We didn't see anything. Yeah, interesting. Interesting thought. I don't know. Maybe just a weird one-off. Yeah. Totally. Thanks, Lev. Good to see you.
I'm wondering if you looked at some of the soluble biomarkers that indicate gamma overproduction, like cystine or gamma itself, that could be used as a surrogate.
No, it's a very good point. I think the question was on soluble biomarkers that could also be used, right?
Because we use CXCL9 clinically all the time
for
gamma overproduction. So I'm wondering if that was looked at here or something you could use instead of phosphostat staining or genetics.
Absolutely, it would be easier. So this was a Luminex. I think we got 56 or something cytokines. I think CXCL9 was on there, but I should confirm. And that was not differentially different, but differentially different. But it was not changed. But no, very good point. And Luminex, of course, is semi-quantitative. I wish we'd had a little more ability to do some ELISAs along the way. Yeah. Those, actually, to your point, those samples are still in my freezer. So if you want to look at them.
Okay, we unfortunately, I'm sorry, we have to close. This was a wonderful talk.
Okay, thank you very much. We end the session with someone who comes to us from farthest away, I think. So Dr. Terje Solhaug comes from Nordland Hospital, Bodø, which is above the Arctic Circle in Norway. And he will talk about CTLA-4 syndrome and aplastic anemia pathogenesis and management.
Yeah, thank you very much for having me today. Yeah, I've been traveling from Bodø, so I'm a bit jet-lagged today. I hope I can manage to get through this lecture. So I will talk to you a bit about the cytotoxic T lymphocyte-associated protein 4 haploinsufficiency and aplastic anemia. And why am I here talking to you about this? Well, I've been involved in a team who has treated and diagnosed a family with 3 family members who all had a mutation in the CTLA-4 gene. So this is the first one. I'm sure you're all surprised that I've made these myself using paint and they're not AI-generated pictures. But this is patient number 1. He was in his early teens, presented with pancytopenia, bruises, and recurrent infections. And bone marrow samples revealed severe aplastic anemia. So he was fortunate enough to have a monozygotic twin brother who was feeling very fine at the time, but when we did a pre-transplant workup, he was also found to have aplastic anemia. So several years later, about 15 years later, their father, who was then in their 60s, he also developed aplastic anemia, but he had been treated before this for warm-type autoimmune hemolytic anemia. He had primary sclerosing cholangitis and ITP, and also diffuse pulmonary infiltrates. So now we had 3 family members with the same disease, aplastic anemia, so we were considering an inherited immune dysregulation condition. So we did a whole exome sequencing, and we found a CTLA4 variant in all 3 of them, the same variant. So then in my mind, I had to find out what is CTLA4. This is a few years ago. It was before we started treating patients with cancer with the CTLA4 inhibitors. So we're just going through very shortly what does CTLA4 do. So the main function here, the CTLA4 is constitutionally expressed on the regulatory T cells, or the helper T cells, and then the conventional T cells, it can be induced during activation. So one of the main functions for the CTLA4 is to bind CD80 or CD86, and thereby inhibiting the T cell from getting activated. And it has a much higher affinity for the CD80, CD86 than the CD28, which gives the positive stimulatory signal to the T cell. And as you can also see, the T cells can produce the soluble CTLA4, which also can block the CD80 and CD86 receptor. And moving forward a bit, treating this patient with abatacept, which is the CTLA4 fusion protein, which will give the same effect as the soluble CTLA4 here. So another important function here is that the CTLA4 ligand with the CD80, CD86 can be consumed by the T cell and removed through transendocytosis. And here, usually the CTLA4 is recycled back to the cell surface, much helped by the lipopolysaccharide responsive and beige-like anchor, LRBA. And if you have a biallelic loss of function mutation, the LBRA, you will also have the CTLA4 phenotype, and you cannot distinguish them based on the phenotype. So the end result here, if you have a dysfunctional CTLA4, is that you have a reduced negative regulation of T cell activation. So how does this fit with aplastic anemia? Well, everybody here possibly knows that this is a T cell mediated autoimmune disease. And what is the biggest difference between regular aplastic anemia and the CTLA4 associated is that when you look at the bone marrow, you will find the diffuse T cell infiltrates, which you can see here in the report from Calvin colleagues with the CD4 and the CD8 staining. And they found the same findings in the flow cytometry, almost complete absence of B cells and infiltration of T cells. So looking back at the patients that we had diagnosed, we found all this in their bone marrows, but were unaware of the clinical implication at the time of the biopsies. So aplastic anemia is just one of many clinical manifestations of the CTLA4 syndrome. So the inheritance is autosomal dominant and has a clinical penetration rate of about 70%. The gene is located on the chromosome 2. And this report from Schwab and colleagues, who looked at 133 CTLA4 insufficient patients, found that the most common phenotype was hypogammaglobulinemia, and they had lymphoproliferation, respiratory tract involvement with recurrent infection, and pulmonary infiltrates. They have cytopenia in over 50%, skin involvement, and also an increased risk for cancer, especially lymphoma. So the clinical manifestation is based on the T-cell mediated autoimmunity or the T-cell infiltration into organs. So when, why, and for that matter, which type of clinical manifestations the patients get is unknown. It's believed that you need a modifier that will induce the autoimmunity, or if the T cells is continuously stimulated, it will reach an internal threshold, and once that threshold is reached, autoimmunity develops. So, treatment. David Egg and colleagues followed 173 patients with the CTLA-4 mutation and tried to summarize how they had been treated. Some of these patients were started treatment before they were known to have the CTLA-4 mutation, and some of them after they were found to have the mutation. And as you can see, the main treatment here is T-cell immunosuppression. There were many different forms of this in this study, mainly using corticosteroids, both systemically and topically, rituximab, sirolimus, cyclophosphamide, abatacept, and cyclosporine. So it's worth noting also that 18 patients in this study were treated with stem cell transplantation, fared very well, 15 still alive, only one of them still in need of treatment, and that is the immunoglobulin replacement treatment. There have been other reports with this mutation that there is a high increased risk of GvHD, and it seems to correlate with how good, well treated the immunity is before transplantation. And stem cell transplantation is the only curative treatment. And as with other monogenetic diseases, possibly in the future, the CRISPR technology can also help these patients. The work had prepared many different sheets for how to screen and manage the CTLA-4 insufficiency, depending on which of the clinical manifestation is the most relevant. And this is their proposed treatment of cytopenia related to CTLA-4. So how did the family fare? This is sadly not a Disney story with a happy ending. So patient number 1 is the one you see as A31. He was treated with ATG and cyclosporine, responded well to this treatment, but relapsed when cyclosporine was weaned off. So he was given a second course of ATG and cyclosporine, and this time maintained on cyclosporine. But after 10 or 12 years, he started developing hypertension and decreased kidney failure. So we tried adding the eltrombopag, did not work for him, so we tried changing treatment to sirolimus, did not work. We tried giving him abatacept, did not work, and he was getting more and more infections. And ultimately he ended up in the ICU with pneumonia and respiratory failure, and he had a bone marrow transplant on the vital indication, which he survived. But had many complications afterwards, and after about 6 months he still had a poor graft function. So we would try to give him a stem cell boost, but unfortunately he died of complications to the stem cell boost. Twin number 2 is faring much better. He was given treatment with ATG and cyclosporine, and is doing very well with the cyclosporine maintenance, no complications, no hypertension, and normal kidney function. Their father was treated after he was diagnosed with aplastic anemia, was treated with sirolimus and abatacept, and had a very good response to this. But he went on a vacation abroad and got an infection and unfortunately died abroad. And during this time, within under a year apart, so the second twin here got his child number 2, which died under 24 hours after birth. There was done an autopsy, and we could not find a clear cause of death in this child, but it was never tested for the CTLA-4 mutation. So all of the siblings of the father is tested and do not carry the variant. The daughter of twin 1 has been tested and does not carry the variant. The first son of twin 2 has been tested and found to carry the variant and is still currently healthy, no symptoms. And then he got dizygotic twins who has not been tested, but one of them has developed type 1 diabetes, so it's highly suspicious that one of them has the CTLA4 variant. Okay. So I'll end with this picture from the Lofoten Islands. This is where I grew up. Yeah. Thank you.
Go ahead, please, with the question.
Thank you very much. I think this last case presentation really highlights a part of what has come up from the previous part of the session. So you mentioned that the father had a history with ITP and autoimmune hemolytic anemias, whereas the children didn't really have the time of other autoimmune phenomena. So this is why aplastic anemia showed up prior in the children rather than in the father. And that leads to the fact that, again, if you have in the adult side clinical or personal history elements directing you to an autoimmune disorder, that makes you may think of CTLA4 or LABA as you mentioned. But in children, you may not have the time for developing anticipatory symptoms. And this is why in our pipeline, we set immunological testing as part of the workup in diagnosis of marrow failure in children, because you may detect subtle Tregs abnormalities, you may detect, and that comes from a study we ran in which about 20% of our population, which was tested for marrow failure, turned out to have an immune dysregulation genes like LRBA, CTL4, etc. So the point is, in adult, you may have probably anticipatory symptoms that you may drive to a diagnosis of non-classical aplastic anemia. But in children, you need to have a wider panel of investigation, even at the phenotype level, meaning immunoglobulins, Tregs, and on cytokines, etc.
Beautiful case again, and it reminded me of Marcin work when he was a student. He worked on CTLA4 in our lab, and I wonder whether there is a connection to it. There is a rare polymorphism that is AA49 polymorphism that is overrepresented in aplastic anemia, not by big means, but in other related diseases as well. And the G allele is protective. In other words, the only homozygous people get the risk, if you wish. Did you look at other variants of CTLA4 in bone marrow failure?
No, we are not doing any more studies. We did check the variant that the family had and found that the mutation was in the exon 3, and there was a decreased expression of CTLA4 on the lymphocytes.
Yeah. So I don't know the genetics, maybe Marcin. I don't think that you remember, but if you do, I would be impressed. But the other thing is, of course, the treatment with ipilimumab, right, which is thousands of patients get this drug for cancer in combination with Opdivo or alone. In fact, I'm very familiar with this and very unpleasant my personal experience. So, and they are cases of aplastic anemia with checkpoint inhibitors, but they are by far out of proportions that one would expect if inhibition of CTLA4 would be. Eventually, everybody with metastatic melanoma gets this drug, right? Yeah. There was no epidemics of aplastic anemia with this, yet it causes iatrogenic deficiency in CTLA4. What do you think?
Yeah, there have been several case reports with the CTLA4 inhibitors and aplastic anemia, and once you stop the treatment, aplastic anemia disappears after a while. And also there has been a study group that have looked at the CTLA4 messenger RNA expression in patients with a genetic disease in the CTLA4 or the LRBA, and patients treated with the CTLA4 inhibitor. And you can see that the patient with the most autoimmune symptoms has the highest levels of CTLA4 messenger RNA in their blood. So this could possibly be a kind of a biomarker for these patients in the future, and especially for the asymptomatic patients, maybe predict when autoimmunity will develop.
I have one last question. The bone marrow histology looked quite distinctive here with very large lymphoid aggregates. Is this representative, and can you screen for the syndrome based on bone marrow histology?
I think you should at least have a higher suspicion of the CTLA-4 syndrome if you find big T-cell infiltrates in the bone marrow. So I know of different patient which is treated by my colleagues further north in Tromsø, which presented with a pure red cell aplasia and also had a similar T lymphocyte infiltrates in the bone marrow.
Okay, thank you very much for this very informative talk and a great discussion. We will close this session now. When are we reconvening? In 10? 11:10. Thank you.